to ED with hyponatremia, which this is a very important, are stable and does not require emergent therapy. So as a practice, most of us at emergency department, whenever we saw a patient with low sodium, we go ahead and start shooting 1 liter of normal saline without knowing is this patient need or require an intervention now or no. So most of our patients who present to our emergencies does not require emergent treatment of their hyponatremia. So for me as an emergency physician, if I am treating a patient with hyponatremia, this is my way, and this is like a way to divide the hyponatremia. Is this hyponatremia need urgent intervention or no? So if I face a patient with hyponatremia, I should ask myself two questions. Is this a true hyponatremia? And the second question will be, is this patient need urgent treatment or urgent correction? So for the first question, for hyponatremia, this is a very famous figure. So as we know all, hyponatremia is sodium below 135. So here will be the pseudo or not a true hyponatremia, when will be either normal osmolarity or high osmolarity. In case of normal osmolarity, like multiple myeloma, hyperlipidemia, this case of hyponatremia will be treat the underlying cause. If the osmolarity is high, as what happened in hyperosmolar hyperglycemia, hyperglycemia, mannitol use and contrast, also here will be treat the underlying cause. So this part of hyponatremia are not the true hyponatremia that need intervention and correction of sodium, rather than correction of the underlying cause. And here we go to the true hyponatremia that we should worry about when the serum osmolarity is low. So this is the osmolar hyponatremia. It's divided to hypovolemic, eovolemic, and hypervolemic. So if I have a hypoosmolar hyponatremia, I should go and check my patient volume status. If the patient is hypovolemic, or eovolemic, or hypervolemic, and we will treat our patient based on the volume status. So this is basically the type of hyponatremia. So then, as we said, the second question is this patient need an urgent treatment? As we know, hyponatremia can cause life-threatening complications as altered mental status, a focal neurological deficit, active seizure. So when does my hyponatremic patient require urgent treatment? If my patient's sodium level is less than 120 milliequivalent per liter, plus one of those three, either altered mental status, focal deficit, or active seizure. So how does I treat my patient in this scenario? Then the medication or the treatment of choice will be hypertonic saline or 3% normal saline. So will be there is a different approaches. This is one of the most commonly used approaches, to give a bolus of 100 ml IV over 10 minutes. Then if needed, you can repeat other 100 ml. So the 100 ml, other people or other references, they go with 1 to 2 ml per kg of hypertonic saline as a bolus over 10 minutes. The target is not to increase the sodium more than 6 millimole over the first 24 hours. And if it was necessary, not exceeding more than 12, to prevent or minimize the risk of myelinosis or central demyelinating syndrome. So this was as for the emergency part of hyponatremia. Then I will go just briefly about the other options of treatment of hyponatremia, which I will not talk a lot about. We'll focus mainly on the emergency part of the hyponatremia. As we said, the hyponatremia, the true hyponatremia divided into three: hypovolemic, hypervolemic, or eovolemic. If my patient, I decided that my patient is hypovolemic, true hypovolemia with hyponatremia with hypovolemic status, so the treatment will be replace the deficit. First of all, replace the volume deficit by normal saline. Then I should apply the calculations to make sure that I am not replacing the sodium more than 6 or 8 milliequivalent per 24 hour. I will not go through these calculations because this is like a complicated, and it's only a equation that you should apply it and enter the numbers. If my patient is hypervolemic hyponatremia, the treatment will be either restriction of fluid and sodium, loop diuretics, and hemodialysis. In case of heart failure, will be restriction fluid and sodium. In case of patient with chronic kidney disease or end-stage renal disease, dialysis might be an option. So it depends on the underlying cause of this hypervolemic hyponatremia. And lastly, the aerovolemic hyponatremia, which can cause by Seada syndrome, by hypothyroidism, and some antipsychotic medication. Here will be free water restriction, uh, treatment of SIADA if it's present, and also one of the common causes of eovolemic hyponatremia is psychogenic polydipsia. So here will be mainly free water restriction and the treatment of this hyponatremia or type of hyponatremia. So this was briefly about sodium, a high yield point, how to treat and how to approach a patient with hyponatremia. Um, this is what I keep mentioning about the scary complication of overcorrection of hyponatremia, which what we call osmotic demyelinating syndrome. It's occur when too rapid correction of sodium happen. Patient with central pontine melanosis have a flaccid paralysis initially, dysarthria, dysphagia, and hypotension. So if your patient if your hyponatremic patient who you started on correction started to have this kind of symptoms during the correction, you should stop all the sodium containing fluids and start administering D5 water immediately to lower the sodium values temporarily. There is other options of medications that you can use. We will not go through it, but this is the only thing, the most important thing that you should anticipate and think about when you start to treat your hyponatremic patient. Think about this complication and try as much as you can to prevent and minimize the risk of this complication. So this was briefly about sodium. I will go to the other very important and common electrolyte abnormalities that we face in emergency departments. With hypokalemia, I will talk basically about hypo and hyperkalemia briefly, both abnormalities of potassium. So hypokalemia is defined as a potassium level less than 3.5. Usually, again, our patient will be asymptomatic. They might present with non-specific symptoms as palpitation, muscle weakness, easy fatigability, depression, muscle pain. But again, it's non-specific except in the severe form when patient have respiratory paralysis, muscle weakness, and all this. It may cause fatal arrhythmias and hemodynamic instabilities. And in rare extent, it causes hypokalemic periodic paralysis, which is a rare disorder characterized by a potentially fatal episode of muscle weakness and it will involve the respiratory muscle also. This is again symptoms of hypokalemia, shallow respiration, irritability, confusion, weakness, arrhythmias, lethargy, and 3D pulse, instability, and mortality. And this is a summary. So again, the same approach. If I face a patient who is hypokalemic, so as an emergency physician, I should ask myself two important questions. It will direct me and it will decide how urgent and how emergent is my intervention. If there is any ECG changes or arrhythmias, or is any muscular weakness, specifically respiratory. The evidence of one of those, it will mandate an emergency-based correction and urgent action. So this is the ECG changes or the arrhythmias caused by hypokalemia, starting by ST depression, flattened T wave, U wave, and ending by prolonged QT interval. This might again lead the patient to have fatal arrhythmias if not treated early. So flattened T wave, U wave, ST depression, and prolonged QT. Prolonged QT is one of the most important and common finding in hypokalemic patients. The other question will be, is there is any muscular weakness? And this will be by history and clinical exam. Be worried about respiratory muscle weakness specifically, because again, in severe form of hypokalemia, and especially if this is a periodic hypokalemic paralysis, patient might present with respiratory failure because of or secondary to hypokalemia. So treatment, the treatment is based on two factors, the level and the symptoms. So you are not treating only numbers, you are treating combination of a number of symptoms. So if your patient have mild to moderate hypokalemia, which showed potassium more than 3, and asymptomatic, this is very important, oral replacement will be enough. So no need to have your patient on IV replacement. So oral replacement plus advising to high potassium diet like bananas, dates, and some and others. Again, if your patient is asymptomatic. If you go to the second part or second option, if you have your potassium level is less than 2.5, or your patient is symptomatic in form of arrhythmias or ECG changes or muscular weakness, here the approach will be totally different. You should start your patient on a cardiac monitor, insert an IV lines, and start potassium infusion. So for the potassium infusion, it should be 10 milliequivalent per hour in the peripheral line, with or 20 milliequivalent per hour in the central line. And you can always add the oral placement at any power, any one of those options. It will facilitate and buy you time and it will correct the potassium fastly. So why here? What is behind the 10 milliequivalent in peripheral? And there are some references they go to up to 20 milliequivalent if you have big peripheral vein like antecubital, but most of the hospital policies they go with 10 milliequivalent per hour in the peripheral line. So go with the safest option, or 20 milliequivalent through the central line. Why? Because potassium infusion will burn small veins if it's concentrated and fast. So this is behind this, to protect from the local complication of the potassium infusion. Hypokalemia also associated, this is an important factor that we forget about sometimes. Hypokalemia is associated with hypomagnesemia. So magnesium replacement should usually accompany potassium. Sometimes you keep treating your patient potassium level, and although there is no response, then out of nowhere you discover that he was hypomagnesiemic. So persistent, especially if you have severe or persistent hypokalemia, always think about magnesium. So you will never be able to correct the potassium without correcting magnesium level. This was basically about hypokalemia. Again, I'm focusing on the important parts and important aspects in emergency. I will not go in details. Lastly, hyperkalemia. So hyperkalemia is defined as serum potassium level greater than 5 milliequivalent per liter. So patients vary from asymptomatic to having severe symptoms, including GI symptoms like nausea, vomiting, diarrhea, neuromuscular symptoms, and cardiac instability. And here is the cardiac instability, the most worrisome and scary part of the hyperkalemia. And we'll talk about it somehow now. Again, this is a summary about the potassium hyperkalemia symptoms. Arrhythmias and ECG changes are the most important thing to worry about in your hyperkalemic patient. About reasons for hyperkalemia, this is somehow important. The most common cause of hyperkalemia is sucrose or a false elevation of potassium. What can cause this? Hemolysis of the blood, starting from taking or extracting blood in a small needle, uh, prolonged using a use of tourniquet, prolonged tapping in the veins, then to the prolonged or the improper handling of the tube that filled with the blood. All these factors can cause hemolysis of the blood. So always, if this is not does not make sense clinically with your patient, think about false or pseudo hyperkalemia secondary to sampling error before jumping to starting management if there is no clear evidence or clinical signs of other clinical signs of hyperkalemia. So always check about this is pseudo or true. Renal failure is the most common cause of confirmed hyperkalemia. And here, the worrisome part of hyperkalemia. Initially, hyperkalemia in the early phases can cause cardiac toxicity by increasing the membrane potential of cardiac myocytes. So initially, the heart will be excited. It will increase the excitability, so and decrease the threshold of any risky arrhythmias. And then, after a prolonged exposure of the to hyperkalemia and at a very high levels, potassium will cause the deprolactin threshold to rise again and leading to overall cardiac function depression, then cardiac arrest, asystole, and others. So this is how hyperkalemia basically affect the heart. Again, as the other two electrolyte abnormalities, if I have a patient who is hyperkalemic, me as an emergency physician, I should ask myself two questions: Is this is a true hyperkalemia? And is there is any ECG changes or arrhythmias? The answer of those two questions will help me to and will direct my management how fast or urgent is my management. True. So as I said, so the hyperkalemia due to leukocytosis, thrombocytosis, hemolysis, poor vein picture technique, prolonged tourniquet, improper handling of the sample. Always this is very helpful. Read the laboratory comments on the sample. So most of the labs nowadays, when you have all the electronic systems, they will write a comment from the lab that this sample is hemolyzed or repeat sample, or they will send you a message that this is a potentially false reading before jumping and treating your patient without looking about what is behind this result. Repeat the level for confirmation if this was not um, clinically justified. Like if you have a young patient with no any background comorbidities, and out of nowhere his potassium is 6 or 7. But the scenario will be different when you have a patient who's in the stage renal disease in dialysis and his serum potassium is 8. So the chances to be here will be different. So okay, in the first scenario, I should make sure that this is true. There is no any sampling error. The second scenario, this is very logical to have this. So measure it clinically with the history and patient background. But always consider false hyperkalemia. And the second question is there is any ECG changes or arrhythmias. So this is the typical textbook changes of or ECG changes in hyperkalemia. Um, Starting from tall or tended T wave to long PR interval, one wide QRS, then to the sine wave. People still are reading from text. Most of us we read text. It's mentioned there. The ECG changes that it's related to the potassium level. This is for theory, okay, from pathophysiology or physiological part, okay, but all the clinical evidence uh, showed that hyperkalemia can cause any cardiac arrhythmias at any level, and the value itself does not always predict the ECG changes or the degree of cardiac toxicity. So it's nice to know at which level at each level of potassium what is expected to change, but in the clinical life potassium of 6 can cause VTAC in one patient and potassium of 7 or 8 in other patients who tolerate chronic hyperkalemia, like in stage renal disease patient, will be with normal ECG. So again, the value itself does not always predict the degree of ECG changes and cardiac toxicity. So treatment, again, after stabilization of a patient, cardiac monitor, 12 lead ECGs. So I have three concepts to follow. The first, the most important, if it's there, stabilization of cardiac membrane, if indicated. The second will be shifting of potassium to intracellular components. And third concept will be removal of potassium. So I'll start talking about cardiac membrane stabilization. Uh, so, first of all, as for cardiac membrane stabilization, the drug of choice will be calcium. Calcium can be used or should be used to stabilize cardiac membrane by restoring the electrical gradient. The usual dose will be 1000 milligram or 1 gram of calcium chloride or calcium gluconate. The difference between calcium chloride and gluconate, that calcium chloride is more potent. It have almost the um, three times more of calcium ingredient calcium comparing to calcium gluconate. It's in the active formula, so it does not need to be metabolized in the body to start to act. Um, the difference here that calcium chloride cannot be used in peripheral line except if your patient is in cardiac arrest. Otherwise, if you are using peripheral line, the only option will be calcium gluconate. The dose of either formulation can be repeated every 3 to 5 minutes if the ECG changes persist. Because so, if I have a patient who is with cardiac arrhythmias like VTAC secondary to hyperkalemia, I give the patient first dose of calcium, and no, still the ECG does not change. So I can repeat the calcium every 3 to 5 minutes until I reach the resolution or the normal ECG back for my patient. So you can repeat it. It's not only a single dose at all. You can repeat it every 3 to 5 minutes. The second part of management will be shifting the potassium to intracellular component um, by using the insulin, 10 units of insulin or zero point 0.1 unit per kg combined with 1 ml of dextrose. Here the dextrose does not work at all for hyperkalemia. The only indication for dextrose here to prevent the potential hypoglycemia secondary to the high dose of insulin. So if your patient is hyperglycemic already, you might not need to have the dextrose. So here, the dextrose only to protect from the potentially hypoglycemia secondary to the insulin. Ventolin and albuterol or beta agonist, it will be the doses will be much higher than the doses we use for asthma. Also, it will work to shift the potassium from extracellular to intracellular component. And finally, sodium bicarb. But here, talking about sodium bicarb in patients with hyperkalemia, sodium bicarb will not work unless your patient is acidic. So with pH less than 7.2 approximately. Why? Because sodium bicarb will work on the hydrogen potassium pump. It will shift the hydrogen inside this outside the cell and shift and get the potassium back if you correct the acidosis. So again, sodium bicarb will not affect your potassium no benefit to give sodium bicarb for a patient with normal potassium, normal pH. And finally, removal of the potassium from the body. Um, Hemolysis is the only reliable definitive method. If your patient have persistent hyperkalemia or refractory hyperkalemia which does not respond to the treatment, the only option is next option will be the dialysis, because as we know, 90% of our potassium in our bodies will be eliminated from the body by kidneys. So if my kidneys are not working, I will not be able to remove this excessive potassium unless I get help from outside, from help by hemodialysis. Um, and the second option, which not favorable, sodium or sodium sulfonate or caxalate, which also bind to potassium in the intestines and help to excrete potassium by feces. Talking about this, the onset of action of caxalate will be like 4 to 6 hours approximately. So it will not get any benefit for your patient in the emergency department. Plus the growing evidence and serious case reports about the significant side effect of caxalate on patients like uh, intestinal obstruction, intestinal ischemia, and other complications. So people here will start to debate. I am from the team who does not prefer to use Kexalate at emergency department because of the unclear benefit and potential or high potential side effect from this medication. So finally, this was my talk about hyponatremia, hyperkalemia briefly. So this is a rapid review about what I talked. So if I have a patient with hyponatremia, again, the two question is this is a true hyponatremia by looking for this algorithm. Then the second will be, is this patient need urgent treatment, which will be if my sodium level is less than 120 with one of those indications. So the treatment will be a hypertonic saline. If I have a patient with hypokalemia, again, I ask myself, is there is any ECG changes or arrhythmias? And the second will be, is there is any muscular weakness or mainly respiratory? And finally, hyperkalemia, ask yourself, again, is this is true or no, and ask and check your patient ECG. It will direct you how extreme or how urgent you should go with your hyperkalemia management and what will be your line of treatment. And thank you so much.
Thank you very much, Dr. Mohammed Arafat, for impressive